get somebody to turn the back light off, or the front light off, rather? Good morning. Welcome to, can you hear me now? Can you hear me? Okay, good. All right, so this is PSEP for February 2014. I'm going to have to stand here because we still have we're broadcasting this on our new system. This is the, I guess we'll have to say the, it's not even the beta test, it's the next after a beta, which I guess has to be a gamma test of the system. So this is going out live to households everywhere. Right. Yeah, you can watch it on YouTube later. We'll continue to have 2 PSEPs for at least this month and probably March, making sure that the system works and that we can work out all the bugs. Then we'll be having only 1 PSEP lecture per month after that time. Yep. So you'll be able to pick up the PSEP either by computer or live, or if you miss it that month, it'll be on the it'll be recorded and it'll be on the system just like the 9th brain was, only it'll be a non-9th brain. So we will adjust your and there'll be more news at 11, as they say. We'll let you know what how many live PSEPs you need to make, and then we'll see if we can work that into the schedule, or if we're going to have continue to have 2 lectures a month. So we're hoping that we can cut down the number of actual lectures. Okay, so our topics today are going to be urology and also gastroenterology. General risk factors for both urological things and GI things are affected by alcohol consumption, excessive smoking, increased stress, ingestion of caustic substances, particularly GI issues, poor bowel habits. So this is not an advertisement for Metamucil, but do it with it what you want. Acute emergencies in the GI and urological systems generally arise from chronic underlying problems. They've had a problem and now there's an acute issue. Now, talking about pain. Visceral pain, pain from the organs, viscera, is vague, poorly localized, dull, crampy pain. Often is referred. The areas of referral, generally speaking, the liver, pain from the liver is referred to the right shoulder blade. Pain from the gallbladder, often referred to the right upper quadrant underneath the diaphragm, and also to the right shoulder blade. Pancreatitis generally pain is referred through to the back. Pain from pancreatitis is often confused with, or can be confused with pain from AAA, for example. Appendicitis, generally the pain is in the pain from the appendix is referred to what's called McBurney's point, which is in the right lower quadrant, but it can also be referred to the right flank. Renal colic is generally felt in the flanks, and then radiating down to the groin. Somatic pain versus visceral. Somatic pain is sharp and localized pain. It is not vague, crampy, dull pain. So, pain from a bruise is felt directly in that area. More of a sharp pain. Now, causes of either visceral or somatic pain could be inflammation, distension, particularly hollow organs distend, and they're quite painful, giving a visceral, dull, achy pain. That includes the kidney. If the kidney swells from urethral obstruction, it's a dull, achy pain. Ischemia, don't forget that of all the things that happen to cardiac and brain also happen in, to a lesser extent, but they still happen in the GI system and the GU system. In other words, ischemia from atherosclerotic disease occurs in the gut, it occurs in the kidney, it occurs in any organ, basically, or it can occur. Now, the vessels that supply the gut are pretty good size, so they aren't as tortuous. They don't branch as quickly as do the coronary arteries, so they don't lay down atherosclerosis quite as fast. But visceral ischemic pain is a real thing. We've seen, and the pain is just like angina, only it's in the gut. All right, general assessment for any patient. Scene size up, scene clues. You know, if you walk in and you find, you know, I always say if you find a very skinny lady with Karen Carpenter music playing in the background and a little bit of vomit in the corner, you probably got a bulimic. So, scene clues, identify and treat life-threatening. The beautiful thing about emergency medicine and paramedicine is that there are few emergencies, and you treat them almost always the same. You do your ABCs first, because the ABCs save people. Focus history, sample history, your history of onset, pain, quality, etc. All the associated system, pertinent negatives. The trick with GI stuff and any kind of interviewing technique is to figure out the pertinent negatives. There aren't a lot of things you have to ask. Do you have any blood in the stool? Yes, no. Physical exam. Well, general assessment, vital signs, you're going for your ABCs again. Evaluating the abdomen. Inspect it. Look at it. Is it distended? Is there bruising? This is an example of what's called Cullen's sign, the first one. Cullen was a gynecologist and described this ecchymotic, purplish, bloody-looking thing to occur in ectopic pregnancies, and boy, that was a fair amount of bleeding to occur there, and also occurs in pancreatitis from a hemorrhage. Gray-Turner sign. Gray-Turner is all one person. Was a surgeon and described pancreatitis as creating an ecchymosis of the flank, generally the left flank, blood pooling in it. But that can also occur, he agreed and admitted, it can also occur in ectopic pregnancies and intra-abdominal hemorrhage from any source. So it's adult. But this just means that this is not bruising, surprisingly enough, in the skin itself. This is bruising this is bleeding from within that's now staining, if you will, the abdomen. So we inspect, visually inspect, listen to the belly. Everyone, you know, should practice a little bit listening to people's abdomen. Be sure to tell them what you're doing when you just pop up there, but listen to it. Your intestine is always moving. It's always making noise, particularly if you're hungry, particularly after you're eating, but it always makes noise. It's not quiet. A quiet abdomen generally means there's a big problem. It usually means there's inflammation of the peritoneum, and so the bowel does not move because it doesn't want to encourage pain, doesn't want to cause pain. Bowel obstruction, which we'll talk about later, generally has periods of quietness followed by periods of intense activity, what is called rushing, trying to push something by the obstruction. Then it goes quiet again. During that rushing time, the patient is feeling pain too. They're feeling visceral pain from distension of that abdomen. Now, palpation, of course, is good. We like to palpate. When people say, I really have abdominal pain, you don't vigorously push on their abdomen. The technique of palpating the abdomen, ask them where it hurts. They'd say, it hurts in the right side of my abdomen. So you start on the left, gently palpating the furthest part away. You palpate in all four quadrants, gently pushing. If they say it hurts, stop. Then go back to the place it hurts more. Once. Push down and say, does that hurt? Does that hurt? And they say, yes, yes, that hurt. Stop that. And then you take your hand away very fast. If they try to hit you or they yell when you take your hand off, that's called rebound pain. And that's the absolute proof that there's inflammation of the peritoneum under that spot. Now, more subtly, if you push on the left lower quadrant and they say, oh, it hurts on the right side, that's called referred pain. Because what you're doing is that means there's a lot of inflammation. Even pushing on the left side makes the right side hurt because you're moving the peritoneum just slightly. Okay, just a quick review of what is the... Do I have a pointer on this thing? I don't know. Quick review of the gastrointestinal. Don't forget that really many of us consider that the salivary glands are the beginning of your gastrointestinal system because the saliva adds enzymes and things to your food to start breaking down particularly carbohydrates. Esophagus is named in with a few nasty medical issues that we see emergently that we'll be talking about specifically later. So esophagus down into the stomach. The stomach has several divisions of the stomach, but for all intents and purposes, just the stomach for you. Most stomachs primarily lie to the left of midline, unless you're a situs inversus person, and those are very rare. Stomach goes into the duodenum. The duodenum is the first part of the small intestine, and the duodenum stops at what's called the ligament of Treitz, T-R-E-I-T-Z, was obviously a German anatomist, physician, and this occurs right there's a ligament that ties down the duodenum, sort of loosely hooks it to the pancreas, to the and to the mesentery of the abdomen. That's important because this is a tether for the intestine at that point. And if you flex forward very rapidly over a steering wheel or a seat belt, that the rest of your abdomen and intestinal moves forward, but the duodenum is stuck at that point. And it can be torn loose, the attachment can be torn loose at the pancreas, so you get retroperitoneal hemorrhage, which does not show up from just simple palpation of the abdomen then, because it's retroperitoneal, it's behind the peritoneum. Or you can get tears of the mesentery itself and get internal bleeding into the abdomen, which then gives you peritoneal signs of intestinal bleeding. So ligamented Treitz never knew that this would be a big deal because they didn't have automobiles in those days. So he didn't think that would be a thing. So after the ligament of Treitz, which is about Well, the duodenum is, give or take, 15, 20 centimeters long. Then you go into your small intestine, the jejunum and ileum, and that has that's a lot of intestine. It's serviced by 3 pretty good-sized vessels in different segments. Then it goes into the large intestine, the colon, ascending colon, transverse colon, descending colon, rectum. The appendix is at the junction of the cecum and the jejunum, or ileum rather, and liver and gallbladder live there. Liver primarily on the right side, although there's a large lobe of liver that goes into the into the left side of the abdomen under the diaphragm. Now it's tucked up underneath the diaphragm, which means it's underneath the upper ribs or the lower ribs. And remember, under deep exhalation, your diaphragm, the dome of the right diaphragm, rises to almost the level of the 4th intercostal space. So just above at the 5th rib. So anything that's in the any injury that's in the lower half of your rib cage is just as likely to be a abdominal injury, intra-abdominal injury, as well as a chest and lung injury. For example, and we'll go at greater exploration of this at another time, but you're all aware of the shooting that was at the vets this week, and one of the injuries that was sustained by the victim was a gunshot wound to the right chest, which broke a rib, punctured a lung, also took a hole through the diaphragm and a hole through the liver. So always be aware of that potential for any kind of injury. So you get a fair amount of blood loss from that sort of thing. Gallbladder lives right underneath the diaphragm, right underneath the liver, so below the diaphragm as well. Pain from the gallbladder generally in the right upper quadrant, referred to the right shoulder blade. Gallbladder is a storage unit only. The most important thing of either the gallbladder or gallbladders are only important organs to the surgeon. It's a way to get your kids to college, as well as the appendix. Pancreas is primarily a retroperitoneal organ. So injuries to the pancreas and diseases like pancreatitis are retroperitoneal primarily, and that's why, besides a little bit of of epigastric pain, you will have a lot of severe back pain associated with it because it's retroperitoneal. The appendix, just like the gallbladder, is important to surgeons. Okay, what are the causes of upper GI bleeding? Okay, this is kind of the list of how it is. Now, peptic ulcer disease, gastritis, rupture of a varix, rupture of a esophageal varicocele. A Mallory-Weiss tear is getting to be less common. Mallory-Weiss tears occur when you vomit excessively and you actually tear a portion of the mucosa during the retching. Esophagitis, inflammation of the esophagus, and then duodenitis, or inflammation of the duodenum itself, which is also where half or more of your peptic ulcers occur. Now, upper GI bleeding, general abdominal discomfort, sometimes severe pain like heartburn, but mostly just discomfort. and hematemesis, which is red blood vomiting, and black blood vomiting, because now, and melena. Melena is black tarry stool. Now, upper GI, the characteristic of upper GI bleeding is either bright red vomiting or melanotic stool and blackish coffee ground vomiting. That's the definition. Now, the reason that occurs, that it becomes black, is because you're bleeding into the stomach has stomach acids, and the acids work on the hemoglobin to oxidize the hemoglobin, so you go from red to a dark blackish color. So anytime you have black tarry stool, you can say without question, this guy is having upper GI bleeding. I know it's above the level of the ligament of Treitz because he's got stomach acid mixing with the blood that's turning it black and tarry. If he's vomiting coffee ground material, say what's coming out of his stomach. If he's vomiting bright red blood and copious amounts, it's probably coming out of the esophagus. It hasn't gotten into the stomach yet. Now, you can have, of course, slight mixtures of that, but this is kind of the way you aim for it. Then, if they have enough, obviously, upper GI bleeding, you're going to check them, check their ABCs, check them for signs and symptoms of shock, changes in orthostatic vital signs. If they tell you they got dizzy when they sit up, don't make them stand up. Just, that's orthostatic. That's a test. That's enough. We don't force them to fall down. A lot of times they'll call you because they passed out getting up off the toilet, and then you notice that they have black tarry stool or bright red blood in the stool, which means it's lower GI bleeding. Now, obviously, ABCs, 2 large bore IVs, if possible, salt solution, and then with GI bleeding, it's pretty straightforward to differentiate between life-threatening and a chronic problem or a exacerbation of a chronic problem, and that's by your vital signs and ABCs. If someone is having chest pain along with their GI, do a 12 lead on them. Now, their chest pain may be from an upper GI problem, but as likely, if they become significantly anemic quickly, they can have ischemic cardiovascular problems because they have underlying cardiovascular disease. Now they're anemic, they're not carrying as much oxygen, so they're getting ischemia. Okay, esophageal varices. The usual cause of esophageal varices, all esophageal varices occur because of portal hypertension. You know, the portal vein, portal system carries food and everything through the vascular system to the liver, and then so it all ends up in the liver. All the portal system ends up in the liver, and the part of the portal system starts at the level of the esophagus, the junction of the esophagus and the stomach, and the portal system ends at your hemorrhoidal veins, tail veins. So anything you have that increases portal system pressure will then start to distend those veins, because veins are very distensible. That's the nature of them. And after, with chronic increased portal hypertension, the veins distend quite markedly. And yes, indeed, you get hemorrhoids as well. Almost everybody who's got esophageal varices will have hemorrhoids too. Now, that doesn't mean you have portal hypertension. If you happen to have hemorrhoids, you're a human being. We have that problem because you have, by definition, standing up on your hind legs gives you some portal hypertension because you're standing up, and that's a long way down there compared to where your liver is. And And so people get hemorrhoids from standing up. People get hemorrhoids from poor bowel habit, particularly straining at stool, because you increase, just by increasing intra-abdominal pressure, you increase that. You get hemorrhoids from being pregnant because you've got increased pressure squeezing on the veins from the baby, big uterus. So that doesn't mean you're an alcoholic with cirrhosis if you have hemorrhoids. But the usual cause of significant portal hypertension that causes esophageal varices, esophageal hemorrhoids, if you will, is portal hypertension from liver damage. You've got increased pressure in the liver from scarring, from cirrhosis of the liver, which scars the liver down, increasing or decreasing the ability of the vein to flow, increasing the pressure, and you end up getting esophageal varices. The varices push out inside the esophagus, and if there's any erosive process, too much alcohol still going down there, cigarette smoking, increased regurgitate because of increased abdominal pressure, increased regurgitation of stomach acid into the lower esophagus. These veins are eroded, and they're big veins, and they're full of blood, and there's lots of portal hypertension, and they bleed like the proverbial stuck pig. And then they start vomiting what? Red blood. Copious amounts of red blood, to the point of becoming extremely shocky. So, hematemesis is the characteristic, and it is painless bleeding. There's no nerve in those veins, but painless bleeding. Now, they might have a little discomfort in the esophagus from esophagitis coexisting, but it's not from the varus itself. They'll have trouble swallowing, partly because they're bleeding into their stomach, and vomiting. Hemodynamic instability, classic signs of shock. They need aggressive airway management because blood is coming up all over the place, and they'll need aggressive fluid resuscitation. Now, so much so, the only way, we used to treat them with a whole variety of aggressive and almost cruel things, as cruel to the ER physician or the gastroenterologist. And the characteristic when I was a kid, when I was in training, was we would put down a big Ewald tube, a big NG tube type thing that had it had a side port with a couple of big balloons to it, and then you'd run ice cold saline down the main channel and ice cold saline in the balloons to push them up and try to coagulate the blood by cooling it enough. But of course, these guys had been vomiting so much that they didn't have a lot of, and being liver disease, they didn't have a lot of vitamin K anyway, so it was almost like being on Coumadin, and this was, this was a mess. The treatment of esophageal varus bleeding now, significant bleeding, any upper GI bleeding needs to go in, have the interventional radiologist, interventional surgeon go in and isolate the vein and the artery and coagulate it, flocculate it, put a thing in to plug up those arteries and stop the bleeding at the source of the vein. You can't go in there, you can't operate and sew these things together. It doesn't work. Veins don't sew together very well. So you try to stop the source, both the arterial and the venous bleeding, with interventional radiology. The only place in town that we can do that 24/7 is Southwest. That's why your orders say, for severe GI bleeding, patient in shock, suspected esophageal varices. You don't have to prove they're an alcoholic. Just suspect that they have esophageal. When they're vomiting that much blood and they're in shock, that's a major issue. That patient is going to die unless they get to an interventional radiologist. So they go to Southwest. Okay, gastroenteritis. Run of the mill. We see that all the time. That can be real severe. It can be not so severe. It's damage to mucosal GI surface. Generally, it's a pathologic inflammation, which could be from an infection. So you have acute bacterial gastroenteritis. It can be from chemical ingestions of things like nonsteroidal anti-inflammatories, ibuprofen, naproxen, things that can damage the mucosa. The reason they damage the nonsteroidals like ibuprofen taken in bulk and chronically decrease prostaglandin synthesis, and prostaglandins are necessary to provide a protective mucosal protectant for the stomach, to protect the stomach against its own acid. So if you decrease this protectant, you end up having the likelihood of gastroenteritis, also the likelihood of ulcers. Alcohol and tobacco use directly affects, causes inflammation in the stomach, and indeed we get acute alcoholic gastroenteritis. Somebody goes on a bender and wake up, embracing the porcelain princess in the morning and begin vomiting up a little blood after going through some dry heaving. I've studied this carefully, so yeah. So, acute gastroenteritis of whatever cause, whether it's bacterial, viral, chemical, rapid onset, severe vomiting, often associated with diarrhea. Hematemesis, once again, either vomiting up bright blood or black coffee ground material. Melena hematochezia is a fancy name. It's the $25 term for blood in the stool, but it's going to be melanotic. It shouldn't be, if it's acute, if it's gastroenteritis involving the lower intestine as well, particularly infectious, or the mid-intestine, the jejunum and ileum, then it could be reddish in color. And you can get enough vomiting and enough diarrhea from this to get shock. So, again, general treatment guidelines, volume replacement. We carry antiemetics for people who are vomiting, who are nauseated. Acute gastroenteritis often is associated with nausea, so it's a perfect thing to use an antiemetic on. Chronic gastroenteritis occurs long-term, and people have, it's primarily microbial, doesn't happen as much in this country anymore, and you follow the same thing. You just establish that it's long-term and chronic because they've had it for a long time. Peptic ulcers, erosions caused by gastric acid. The mucosa is normally protected. Things that will unprotect the mucosa, alcohol and tobacco use, non-steroidal anti-inflammatories, including aspirin. Now, that's why very few people take much aspirin. People take aspirin, they recommend that, once you get over 60 or so, that you take a baby aspirin a day to protect against thrombosis, coronary and cerebral thrombosis. But that's a very tiny amount. That's not going to knock down. And you notice that almost all those pills are given in what's called an enteric form, or baby aspirin you chew and swallow, and it's already broken out. It doesn't have much effect on the mucosa at that point. And the enteric aspirin is not even dissolved until it gets into the lower intestine, so it doesn't have that effect on your stomach. H. pylori is a bacteria. We found that a number of ulcers are actually appear to be caused by this bacteria, because the bacteria is there, and you can test the patient by a blood sample. The bacteria is there in about 40% of ulcers. So you treat the bacteria, and the ulcer goes away. Well, that seemed to make sense then. So it's still thought that H. pylori is something we would normally check if you come in with symptoms of an ulcer. Now, terminology for ulcers are where they are. So you either have a gastric ulcer, which is an ulcer in the stomach, or you have a duodenal ulcer, which is still peptic ulcer because there's a lot of stomach acid still present when the food bolus ends up into the duodenum. So about 40% or more of ulcers, peptic ulcers, occur in the upper portion of the duodenum, which is still red hot as far as acidity goes. Peptic ulcers hurt. They have generally visceral and somatic type of pain. They will have severe epigastric pain. Now, some people describe it as heartburn. Remember, half of the heartburn that we see might be actually cardiac in nature. So be cautious about it. The old thing that no one ever died of GERD or gastroesophageal reflux disease is not true. They did because they were mistaken. Their cardiac problem is mistaken for GI pain. But their pain from a peptic ulcer may make you think, I better do a 12 lead. It should make you think that. You can get a hemorrhagic rupture of a peptic ulcer. And that then has acute, severe epigastric and sometimes left upper quadrant pain associated with hematemesis, fairly bright blood mixed with darkish blood, melanotic stool because it's peptic ulcer there. And if they actually rupture the stomach, they'll have immediate signs of peritonitis, rebound tenderness, rigidity, shock, and there'll be air under the diaphragm and gastric content under the diaphragm, which is not good for them. And that's obviously a severe emergency. The beautiful thing about treating peptic ulcer is you treat the ABCs, bring the patient in. Now, if they're not shocky, consider pain medication. Since we have fentanyl now rather than morphine, your definition of shock and pain is a little bit more fluid, so that if somebody has a pressure of 90 and severe pain in the right upper quadrant, I don't have any hesitation with you giving them small aliquots of fentanyl. You're not going to drop their pressure because you're not going to have a histamine type reaction. Lower GI bleeding. By definition, below the ligament of our friend Treitz. Usual causes of GI, and the number one cause in the country of acute lower GI bleeding is diverticulosis, which we will talk about in a minute. Then there are colon lesions, and colon lesion we all worry about is cancer. Rectal lesions, the most common thing is hemorrhoids. Then the inflammatory bowel diseases, ulcerative colitis, and Crohn's disease. So, lower GI bleeding. What are the signs and symptoms? Well, acute versus chronic. Acute, copious amounts of reddish blood bleeding. And I say reddish because it can be bright red, which means it's usually low down in the colon, or a huge amount of bleeding, or it's kind of maroon-colored, jelly-like kind of stuff because it's taken its time working down and it's clotted and it's been partly digested by the intestinal thing. Now, no acid in there, so it's not going to turn black. If it's black, it came from the upper GI. But if it's maroon-colored, jelly-like, it's from the mid-intestine generally, or the colon. Most chronic GI bleeding, you won't get, the most common cause of chronic GI bleeding first is upper GI bleeding of small amounts. So people will have a little blood in their stool, or they won't even, it won't look black, it won't look, it'll be small amounts, and old people get chronic anemia from just little tiny GI bleeds over a period of maybe a year or more. This is why when you go in for your routine exam, we do a stool guaiac check to make sure you don't have any microscopic bleeding in the stool. Abdominal pain is visceral type of pain from the lower GI. It can be sometimes localized. In the case of diverticulitis, in inflammation of the diverticula, you'll end up with pain in these. It'll be referred to a specific point, generally the left lower quadrant in the abdomen, sometimes into the back. Significant lower GI bleeding obviously will cause shock. So once again, you'll be evaluating for those. And the treatment guidelines are ABCs, IV access. Anybody who's got significant bleeding should always have supplemental oxygen, because their oxygen carrying capacity is decreased by the fact they don't have as much blood anymore, as much hemoglobin. So you dissolve a little bit in the serum. Well, ulcerative colitis. We don't know what really causes ulcerative colitis. It's idiopathic inflammatory bowel disorder, seems to run in families, although there's not a clear genetic trait. Seems to be related to, it's made worse when patients are under stress. So, it may be an autoimmune disorder. There may be environmental factors that play into it. It may even be infectious, but we don't know the exact cause of it. But it's an inflammatory disorder, and the severity is entirely related to the extent of the colon, colitis, colon, the extent of the colon that's involved. Ulcerative colitis is recurring but occasional episodes of bloody diarrhea. Now remember, bloody, not black. Bloody diarrhea or stool containing mucus. Generally, it's got both, mucousy stuff plus some blood in it, streaks of blood. Colicky abdominal pain, cramping abdominal pain. It's an inflammatory thing, so it's cramping. Nausea, vomiting, because the colon isn't working well. The colon isn't moving things along. The rest of your GI tract sort of reverses itself. Occasional fever, weight loss. Severe cases have copious diarrhea, copious amount of bleeding and mucus, and they become shocky. They become sometimes septic as well. So, obviously, treat for that. We treat shock. If they're nauseated, antiemetics, we give them antispasmodics in the hospital. You don't carry anything really for an antispasmodic. Something like Valium will not work. If they're having pain, to be honest, narcotics are a good antispasmodic. So if they're not shocky, if they're having severe crampy pain, I would not hesitate to give them a little fentanyl that may help reduce their cramping. Certainly make their pain better too. The classic antispasmodic in medicine was opioids, oral opioids to treat severe abdominal cramping and diarrhea. to this day things like Lomodal and loperamide for diarrhea of travelers. It's basically an opioid agonist. So, now the bad thing about ulcerative colitis is you have continual episodes of inflammation. It's almost always associated with the development of, it's highly associated with the development of colon cancer. So if people have chronic, recurring, multi-episodes per year, they generally end up with a colostomy as a preventive measure. Then they don't have ulcerative colitis anymore. They have no colon. Crohn's disease. Oh, once again, here's another disease we don't know why. It can infect the entire GI tract, including, well, basically from the duodenum down to the into the rectum. Pathologic inflammation that damages mucosa, causes hypertrophy and fibrosis of the underlying muscles, causes fissures, fistulas, which are openings in between. You run a fistula between one part of the intestine to the other part. It's a little bypass tract, but it's not good. It's not normal. These can all get infected. These can rupture. They can have all sorts of bad things. GI bleeding is a characteristic of Crohn's disease. It's a chronic thing again. It's not the first thing. You know, you can't diagnose Crohn's disease when somebody calls you up and say, hey, I just had a little GI bleeding this morning, a little bright red bleeding. You don't say, oh, that's Crohn's disease, because this is a chronic problem, and it has to be chronically treated then, too. Clinical presentations vary a lot. GI bleeding, nausea, vomiting, diarrhea, abdominal pain, fever. Most of the time when you go out on somebody who has Crohn's disease, they know it, and they'll tell you they have Crohn's disease, and now they're having severe pain, bleeding. You treat them for what you find. Pain medication, etc. Diverticulitis and diverticulosis. Well, diverticulosis is little out pockets in the mucosal lining of the intestinal tract. Not of the intestinal tract, of the colon. The colon is a funny organ because it's muscle. You see this funny stripe that goes up and around. There are 3 muscle stripes on the colon. It's a most of the intestine have longitudinal muscle, so that the small intestine cramps. The muscle for the colon is along this stripe, basically, and it's linear down the colon, and the colon doesn't contract like the small intestine does. It sort of bunches up, sort of pulls itself together by these muscle bands. But in between the muscle bands, that mucosa is fairly weak. And so increased pressure inside the colon causes little balloons to occur. So they're little out pockets of the mucosal lining. This is common in the elderly. I saw a study which showed that probably 85% of the population of the United States has one or several diverticula by the time you get to be 40. May be related to the national eating habit, the national bowel habit. It's hard to know exactly, but it's also characteristic of creatures that stand on their hind legs, too. Increased pressure inside the colon at all time. What happens with, so you have these diverticula, and they're fine most of the time. But because it's a little pocket, like an appendix is a little false pocket, it can get packed up with stool, it can get packed up with bacteria at times, and occasionally then it'll get infected and inflamed, and that's called diverticulitis. So diverticulosis is not not a treatable problem. It's not inflamed, it's not causing any pain, it's not causing any suffering. Diverticulitis is inflammation, possibly infection. It can lead, these things can leak, by the way, and cause an abscess because the mucosa is fairly thin there. They can bleed from the diverticula, causes reddish bacterial bleeding, or reddish GI bleeding. Diverticulitis hurts because it's an inflammation, and it's usually localized to wherever the diverticula is. The diverticula is lying near the abdominal wall. It's probably going to hurt at that point, and it will have rebound if there's significant peritoneal inflammation. You can have fever because it's an infection, an inflammation, nausea, vomiting, and occasionally severe GI bleeding. Treatment depends on what they have. So if they have severe pain, you can think about pain medication. If they have nausea and vomiting, treat them for nausea and vomiting. They need an IV. If they're shocky, they need to be treated for that. And they can have significant bleeding. When I had my GI bleed, it was from a diverticula, and I ended up with an AV fistula, a vein artery connecting in the diverticula, and then when it decided to break loose, it really bled like, once again, the proverbial stuck position. And happily, they did start the IV on me. So, hemorrhoids. Well, we already talked about the etiology of hemorrhoids. Hemorrhoids will break. Usual sign of hemorrhoid is limited amounts of bright red blood associated with a stool, having a stool. And it stops. Makes people very excited, of course, because they have blood in the stool. I always ask people, okay, do you have, was the blood in the toilet? I don't know, I didn't look, they say. Was the blood on the toilet paper? I said, I didn't look. I have a question. How do you know when you're done? Of course, they don't. It's limited bleeding from a hemorrhoid. Hemorrhoids can be very painful when they get thrombosed, because the hemorrhoid, because it's a big bulgy vein, and blood's going through it very slowly, and they've got some increased pressure. Maybe stopped in that hemorrhoid for a while, and the blood coagulates, and it becomes this rock-hard little thing inside the vein, and that's quite painful. They probably won't call you for that alone. People don't call for pain as much as they call for GI bleeding. They get very excited about blood in the stool. So, bright red blood could also mean other things than hemorrhoids. It could mean lower colonic, mostly rectal, your rectum, which is the lower end of the colon, could be bright red bleeding from there. But most bright red bleeding, in my experience, is rectal hemorrhoidal. Usually stops, too, after they're done, shortly after they go to the bathroom. Bowel obstruction, blocking the hollow space of the small or large intestine from whatever reason. Could be partial, could be complete. Usual causes are hernias, intussusception, volvulus, adhesions, and bowel infarction. Remember, like having angina, having a heart attack in your gut. Now, this is an example of intussusception. Intussusceptions occur in the extremes of age, actually, the real extremes of age. Children get intussusceptions probably because their bowel is so mobile. It's thought with the you have to have a kind of redundant mobile intestine in order to get an intussusception, and there has to be a point, an inflammatory point, an irritated point of the bowel that gets caught inside itself. And the best way to think of an intussusception is when you take a sock, put your hand in the sock, grab the toe, and pull it inside out. So what happens is that point gets sucked down inside the intestine, and it goes down in there until it can't go any further, and it gets stuck. And then that inside piece, it's inverted now, all of its blood supply is cut off too, or most of it. And it starts leaking from the mucosa, gets more edematous, leaks some more from the mucosa, and then you get bleeding. The bleeding characteristic of intussusception is, in children, is called currant jelly stool. Currant, you know, the fruit currants, which is like sort of like a raisin. Currant jelly stool. So it's a jelly-like, reddish, maroonish kind of color. Kids that are at risk for this are usually somewhere between 3 months and 2 years of age. Then old people, older than 71. Hernias, you get the most common hernia we see are inguinal hernias, primarily in men, although women get inguinal hernias too. There are two types of inguinal hernias. One's called the direct inguinal hernia, which means that the part of the bowel goes down, that there's the inguinal canal in the groin is generally speaking, a closed passage for most of us, most men. It's a canal, a passageway that the testicle descends into the scrotum at about age 7 months of gestation, coming from its origin, which is around the kidneys, travels down through the bowel, through the gut, hauling along its nerve, artery, and vein, goes through the inguinal canal, ends up in the scrotum. That's the way it's supposed to be. That's the way it is for most people. And this canal closes off by the muscle tissues and fascia. But it's always there as a potential thing. Some people, it opens up, and then a piece of bowel or omentum or fat can migrate down the canal, and it makes the hernia. It's not a problem. The hernia is not a problem, except it's there, unless it gets stuck or incarcerated, or the bowel twists inside and then shuts off its blood supply, and it becomes obstructed, and it's an acute emergency, and that's why we try to fix most inguinal hernias. Now, there's also an indirect inguinal hernia, and it seems odd because you'd think that would really be the direct, where you actually have a defect in the muscle wall, and it's a bulge right there, but it's not in the canal itself. It's a rent in the muscle wall itself. Either way, you can get stuck in there, causing a problem. Volvulus occurs in children, again, very mobile bowels, and old people with very redundant. Your bowel happens to get bigger as you get older, your belly gets bigger, you have bad bowel habits, your colon distends, and your colon, because it's so loose and so mobile and so active, it can turn on itself sometimes, and you end up making a twist, like taking a plastic bag and making a twist tie in it. That's not good for your bowel. Things can't move through it. Bowel obstruction occurs. Adhesions occur from previous inflammation in the abdomen, and the usual thing is from operations or from rupture of an organ, it's a gallbladder or something, into the bowel. Pelvic adhesions occur from ectopic pregnancies. Anything that bleeds into the people who've had car wrecks and end up having a splenic injury and bleeding in the abdomen. Unless you clean out all that blood, they get tremendous amount of adhesions. So that's why you need a good surgeon for that sort of thing. Bowel obstruction, patient has visceral pain, poorly localized. Yeah, my whole abdomen hurts. Or, oh, it sort of hurts all over. It hurts down here, it hurts up here. They may be hemodynamically stable, particularly if it's been there a little while, like hours to days, and they've had nausea and vomiting associated with it. They haven't been taking fluids. They get distension of the abdomen. This whole chunk of bowel that's not working anymore distends. Anything distends in front of it. Peritonitis, as the bowel wall loses its integrity, ischemia begins to get peritonitis, begins to exude stuff from the inside of the intestine. You get free air if the thing ruptures. Your exam of the patient, the belly's probably distended. If you tap on it, it probably sounds a little balloon-like because it's distended with air, with gas. The beauty of it is treat what you find. A few accessory items to go through quickly, unless you want a break. It's been an hour. You want a break? Okay, we'll take a break. Classic person who gets appendicitis is a 7-year-old. That's the classic age group, 7 to 9 years of age. Young adults, of course, I have seen and I have removed. I've helped to remove appendices, acute appendicitis in people in their 80s. So it can occur. Anyway, it's an organ that's just a blind pouch, and it gets backed up with foodstuffs, bacteria. If it gets infected, it then has nowhere else to go, and it's an infected organ. And because it's infected, it begins to swell, it gets edema, it cuts off its blood supply, it gets gangrenous, and it can break. And then when it breaks, it dumps food and bacteria into the peritoneum. You get acute peritonitis, an abscess, and or you can die from peritonitis, generalized sepsis. So, appendicitis generally starts as diffuse colicky pain. It's not very severe. It's not localized initially. It's not for the first several hours, maybe even days, that it localizes first around the umbilicus, so it's periumbilical, and then perhaps into the right lower quadrant. Now, if the appendix is down low and behind, you don't have right lower quadrant pain. You have pain that might be in the back. Sometimes you don't have any abdominal pain at all, but you have the periumbilical pain still. Nausea, vomiting, low-grade point. McBurney's point is that spot between the iliac crest and the pubic bone, so it's right in the middle there. That's the classic point. Classically, they don't like you to move their leg. They don't like you to move the abdomen because that means they have peritonitis. They don't like you to push on that right lower quadrant and then take your hand away very fast. That's the classic. And whenever I say anything classic, that means you will actually find it less than 50% of the time. Appendicitis is a very difficult thing to diagnose often. And in the days before, we used to take out a lot of normal appendices because we thought they had appendicitis, and we missed appendicitis. Nowadays, they'll do everything from ultrasounds to CAT scans to prove it. So, very seldom do you have to do any supportive treatment for appendicitis. So, just do your normal stuff and bring them to the hospital. Transport them for abdominal pain. Now, if it's female, you can't be sure. We always ask women of childbearing age, when their last period was, if they could possibly be pregnant, because ectopic pregnancies often mimic this. If you have a shocky patient, it's probably because they have a burst appendicitis with peritonitis and they haven't been seeking treatment. Cholecystitis is inflammation of the gallbladder. Now, you can get chronic cholecystitis, which is a bacterial infection. Most cholecystitis, or a lot of cholecystitis, is associated with cholelithiasis, which is stones, gallstones. Now, you can get cholecystitis without stone from, it's associated with burns and sepsis and diabetes and multi-organ failure, but that's, you know, that's more uncommon. Most common thing is gallstone associated with cholecystitis. Generally with cholecystitis and with gallstones, you have upper right quadrant abdominal pain. Murphy's sign is palpate the upper. Normally you wouldn't feel the gallbladder or the liver, but palpate under the midclavicular line in the right upper quadrant. Put your finger, your hand under there, and ask the patient to take a deep breath. Now remember, they're lying on their back. They take a deep breath. The inflamed gallbladder comes down and pokes on your finger, and they go, "Ow!" and it hurts up into the shoulder or into the right upper quadrant. The usual history of cholecystitis, they'll call you because they have right upper quadrant pain, nausea, and vomiting. Classic history of cholelithiasis is that they have a fatty meal, and so eat a pizza, eat something with butter in it, eat something fatty, because the gallbladder tries to contract as soon as you have fats in the intestine, because it wants to put liver bile in there to help to digest the fats. So when it contracts, if you have a stone in there, the stone gets stuck into the duct, and that causes severe pain because the gallbladder goes into spasm and then trying to squeeze that stone out. So pain, nausea, vomiting. If they have a fever, that means they really have inflammation. They have cholecystitis. Pancreatitis. Common cause of pancreatitis: alcohol abuse, gallstones, because it plugs the common bile duct, and then the pancreatic enzymes and liver bile back up into the pancreas and start auto-digesting the pancreas, which it doesn't like. Elevated serum lipids, so people who have high cholesterol have a higher risk of pancreatitis. People with diabetes have a higher risk of pancreatitis. Certain drugs can cause pancreatitis. So it's an inflammation of the pancreas. Most common cause that we see in this county is alcohol abuse. Or recurring pancreatitis. After you've once had pancreatitis, you're at risk again and again and again. A lot of times when you get people with diabetic ketoacidosis, they complain of severe epigastric pain. They are having a type of pancreatitis at that time associated with their diabetes. But that often brings them to your attention because they're having pain. Then you diagnose and you say, "Oh, well, their glucose is too high to count, and they smell a little fruity, and they're a little shocky." Well, I'd say that's diabetic ketoacidosis with associated pancreatitis. Mild pancreatitis has just epigastric pain, some abdominal distension, nausea, vomiting. That's mild. We test them. We test the pancreatic enzyme levels to be sure to see what. Severe pancreatitis has all of the above, plus shock, blood loss, respiratory failure. They may have bleeding into the abdomen. They may have a Gray-Turner sign. May have a Cullen sign. They have bad stuff going, and they will end up with shock and a respiratory, multi-organ failure. If they're not shocky, if they're having extreme pain, treat them with pain medication. If they're having nausea, vomiting, treat them with antiemetics. Hepatitis, injury to liver cells. inflammation or infection, but you can get acute alcoholic hepatitis as well. So anything chemical or viral, sometimes bacteria, sometimes parasitic things that attack the actual liver cell itself. Trauma can cause hepatitis. Risk factors are all of the above. Tattoos, body piercings, mother-to-baby transmission, sharing needles, that's the biggest one, of course, sharing needles, sex, always a risk. Blood transfusions. Hepatitis A, classic infectious hepatitis, fecal oral spread, self-limiting, takes about 2 to 6 weeks to incubate, lasts about 2 to 8 weeks. Generally very minimal. Hepatitis B, serum hepatitis, the stuff that we immunize you all against. The reason we immunize you against is the effect of serum hepatitis, which can be spread by blood, by seminal fluid, by most any body fluid, actually. Tears, no. Saliva, very little worry there. The problem with it is that most of the effect of serum hepatitis is pretty mild. Most people get not much worse than they do with hepatitis A. But some people become, number one, chronic carriers. Some people get severe liver ischemia and necrosis, and it can lead to lifelong liver problems, hepatomas, chronic hepatitis, and kind of ruin your life. Hepatitis C, blood transfusions, primary way that that's spread, although it's also spread. We know that there's some exposure, less risk than hepatitis B for EMT personnel, but it's still there. So if you do test positive for hepatitis C and you haven't had a blood transfusion and you're not a known IV drug user and you've not made it a habit to spend most of your life with persons of your own sex, then you probably got it from on-the-job exposure. And that's counted as far as workers' comp kind of stuff goes. Hepatitis D, it's an odd one. It's just there. It's activated by hepatitis B. Hepatitis E is waterborne, sort of like hepatitis A, except that's only just foodborne. It's waterborne. Third world country, hepatitis G, super infector. Signs and symptoms of hepatitis: upper abdominal tenderness, fatigue, loss of appetite, weight loss, malaise. Incidentally, kids who get really sick with mononucleosis, the reason they're so sick is that they have a low-grade hepatitis associated with mononucleosis. Clay-colored stools, jaundice, scleral icterus. What's happening is that liver bile, hemoglobin isn't being converted to bilirubin, going out in the liver bile. It's going into the only water the soluble form that goes into the serum. That increases the bilirubin in your serum. So that's where the icterus comes from, the yellowness, because the bile isn't going out in the liver. Bilirubin's not going out in the liver bile. That's what makes your stool brown, and so your stool turns pale, clay-colored. Photophobia is associated with the icterus, and nausea and vomiting also with icterus. It itches too. A lot of itching with icterus often. Vaccinations are available for both A and B. I always recommend people, if they like to eat raw oysters, go ahead and get your hepatitis A shot. That's not included by your as part of your job description. Your Bs should be provided for you by your department. Okay. Into urology briefly. Urinary tract system performs a bunch of interesting things we think of the GU system as, oh, well, we're just making urine. Well, making urine is a big deal. This is what maintains your blood volume, proper balance of water, electrolytes, and pH. We always think that the way we mostly manage pH is to do CO2, because that changes your acid base real fast. But that's the major organ that maintains your internal homeostasis and pH is the kidney. It's excreting hydrogen ion all the time, helping to maintain your acid-base balance. The respiratory system does it very fast, but not for long term. It also removes toxic wastes of all sorts, just like the liver does, maintains arterial blood pressure, and controls the development of red blood cells through a hormone that's produced. Kidney is basically the hilum, the medulla, the pyramids, which are the collecting system, or the beginning of the collecting system, the papilla, which is the base of the collecting system where it all comes together, to the renal pelvis, which actually drains things out. Now, the nephron, which is where the action is, you've got the afferent. I need a pointer here. Well, I don't have a pointer here. I don't think I know how to make this thing. There's the thing you're supposed to be able, oh, maybe I can you see this now? Okay. So, artery coming in here, vein going out. In between, you can see there's all this network of vein, and the arteriole and the venule come together here in the glomerulus. The glomerulus is where the venous and the arterial system come together, and this is where where urinary function begins. Around the glomerulus, this little organ, is a thing called Bowman's capsule. At this point, the arteriole and the venule are right together, and water and salts could go right across the junction there. But instead, what happens is that water and salts begin to be diffused, just by simple diffusion, come out into the proximal tubule as it goes down. Now, it has a certain amount of water, a certain amount of glucose, a certain amount of sodium, potassium, chloride. As it goes down through this, it passes by this series of venules, and selectively things begin to get either reabsorbed or excreted into this collecting system. This is called the proximal tubule, and it goes to a thing called the loop of Henle, comes back on itself. And the reason it comes back on itself is that you then get possibilities of diffusion, not only from the venules into the tubule, but you get possibilities of diffusion between the descending portion and the ascending portion. It's like a heating core. And as the urine passes, as the beginning urine, the proto-urine starts down this and recurs to this, selectively, generally in a healthy one, sodium is reabsorbed, potassium is reabsorbed, but less so than sodium. Hydrogen ion is excreted into the urine, which makes it more acid, ultimately. Glucose is selectively reabsorbed, And a little bit of water is probably reabsorbed too, depending on what the needs of your system are. So the whole concentration of solutes in this changes markedly here, and urea begins to be excreted, which is urea is a breakdown product of protein, basically, and it's being excreted into this system, what ultimately occurs goes through what's called the distal tubule and then to the collecting duct. And in the distal tubule and the collecting duct, urine is further concentrated because water is selectively reabsorbed from that. The net effect is you start out with a very dilute product at this end, and you end up with a very concentrated product at this end. How concentrated depends on what your water balance is internally at that point. So, formation of urine, the glomerular filtration, we do a thing, we will do tests in the hospital called the glomerular filtration rate. Reabsorption and secretion occurs by both simple diffusion, normal osmosis, and then facilitated diffusion. Glucose goes by facilitated diffusion. Urea goes in by a facilitated diffusion as well, but it goes in the other way, goes into the, and then active transport of both kind of things. And this all depends on ATP. You have to have adequate energy source. That's why persons in shock, persons who don't have adequate supply of ATP substrate to their kidneys fail. Now, diuresis means increasing urinary output, if you will, urine output. Antidiuresis is preventing water loss from formation of too much urine. The tubes I said are the ones that handle both glucose and BUN and creatinine in the ascending descending loop. The renin-angiotensin system, which is part of the kidney, and that occurs at the level of that arteriolar control. Renin is produced from the kidney in response to inadequate blood flow or inadequate blood pressure. That stimulates conversion of angiotensinogen to angiotensin, and they come in a couple of flavors of angiotensin, but angiotensin causes vasoconstriction and retention of fluid, increase of salt to retain fluid. So that's one of the ways that we maintain our blood pressure through the kidney. It also stimulates the production of aldosterone, which retains salt, raises your blood pressure. Erythrocyte production is controlled when the glomerulus senses decrease in red blood cells, and it's probably based on an oxygen kind of carrying capacity thing. It produces a hormone called erythropoietin, which goes to your bone marrow and says, make blood cells, make red blood cells. So the kidney is, not only does it maintain your pH, it maintains your blood pressure, it helps to maintain your blood pressure, helps to maintain your blood volume, helps to maintain your red blood cells. So it's kind of an important thing. Aldosterone also very, very much affects glucose. Your kidney affects how much glucose is reabsorbed, how much glucose goes out in your urine, so diabetes can have some material deleterious effect. Now, problems with kidneys are either going to be inflammatory, immune-related, infectious diseases, physical obstruction of the kidney, of the outflow or sometimes the inflow, and hemorrhage. Now, assessment of any patient. Now, when you're talking about urological things, they often are reflected in discomfort. So, appearance of the patient. Patients with, for example, kidney stones are really uncomfortable. They cannot find position of comfort. They're generally sitting up. They don't like to. They don't like to lay down. They don't like to move around. They don't like anything. They're also nauseated, often vomiting, severe pain in the flank. People who lay with their legs drawn up don't want to stretch their peritoneum. That's a hint. People who have relief with walking, well, it's not so much relief, it's they can't find any comfortable position, so they might as well move around. Level of consciousness, find out if these changes are acute, chronic. Let me tell you, they will call you if they have a kidney stone because it's acute, sudden, severe pain, often the worst pain they've ever had. We'll look at their apparent state of health, their skin color, whether they have what's called a uremic frost around their mouth. That will indicate this is a chronic problem. Look for distension in the abdomen, just like you're examining the abdomen, distension, ecchymosis, previous scars, pain with palpation or percussion, pain, localizing any pain, rebound, kidney pain often can be elicited by putting your hand across the flank, tapping your hand. If it's kidneys involved, they don't like that. They'll tell you that. Vital signs. And then your management, once again, the beautiful thing about it is normal management. ABCs, pain medication for pain, anti-nauseants for nausea, if their blood pressures are okay. Keep them NPO, just like with abdominal pain, any kidney pain, anything. We don't want them to have anything by mouth. Generally, they got nausea and vomiting anyway, so that makes it easy. Position of comfort. Acute renal failure, ARF. Sudden drop in urine output to less than 400 to 500 cc's per day. Now, that's our definition because I don't want you staying with the patient that long. Generally speaking, acute renal failure is less than 30 cc's of urine output per hour, but you're not going to know that. They may tell you that they're not urinating normally. Well, what's the most common cause of people not urinating normally? It's that they're dehydrated or shocking. And this is the same difference. Now, you can get acute renal failure from either pre-renal causes, renal causes, so the kidney itself, or after the kidney. Obstruction distal to the kidney, so it's either in the ureter or the urethra. Now, pre-renal causes, most commonly cardiac failure, shock, severe cardiovascular collapse. There's not enough blood flow going to the kidney. Now, hypovolemia, hemorrhage and dehydration from burns. So any hypovolemia, shock, but think of hemorrhage and burns. You're also going to produce, with burns, you're going to get the possibility of myoglobinemia and hemoglobinemia. So hemoglobin and myoglobin in the blood, which goes to the tubule. It's excreted and it plugs the tubules up. Acute renal failure. And then renal arteries, you can get a thrombosis of a renal artery, which kills the kidney right then and there. And that causes acute kidney failure. Now, acute renal failure, usually small vessel damage. So either immune-related, and the one to think about is what you get after a strep infection, which is why we treat strep throat with penicillins now, so people don't get acute glomerulonephritis, strep-induced autoimmune disease, because that can cause acute renal failure. You can get acute tubular necrosis from, remember, the tubes themselves can necrose from either usually toxins or ischemia. And then acute pyelonephritis, which is an infection. And that causes, that kills the kidney tissue itself. Causes acute pyelonephritis. Post-renal, the usual thing is obstruction of both ureters. Now, there can be stones, tumor, blood clot, or most commonly we see it from little old guys with bladder neck obstruction from prostate, sometimes from a big stone that gets into there. So, acute renal failure, your focused history will note change in urine output. Swelling in face, hands, feet, or torso. You get edematous, but now your face, it's not just like a chronic congestive failure where you got, dependent edema. Now you have puffiness of your face, puffiness of hands, which is fairly unusual in congestive failure, and general puffiness. Heart palpitations or irregularity. Why? What are you thinking about with your heart and kidneys? Potassium, 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 and other things, but mostly changes in mental function, too. Now, so your physical assessment, alter mental status, hypertension, tachycardia, EKG indicative of hyperkalemia, which is what? What's your first thing in hyperkalemia? Peak T waves. After you have peak T waves, you end up getting flattening of and widening of the QRS, decreasing of those T waves, spreading out of your QRS, and as you get more and more hyperkalemic, this whole thing begins to, your P waves start to disappear, your QRS gets wider and wider and kind of approaches a sinusoidal pattern. That's variable for the person. If you've never had acute hyperkalemia, then the symptoms will show up quicker at lower levels. People with chronic kidney disease will have it longer. Now, peak T wave. I want to show you something with peak T waves because this will come up after a little bit. Okay, peak T waves. This is peak T wave. This is certainly peak. God, this T wave is bigger than the QRS complex. This is a peak T wave. This is a peak T wave. These are all peak T waves. So peak T waves are occurring in several leads. The vast majority of the leads, you've got peaked T waves. These are not normal-looking T waves. But they're occurring in a lot of different places. In other words, it's general throughout the 12 lead. Indeed, actually, even though the T wave is upside down in AVR, which is where it's supposed to be, this is pretty prominent P wave or T wave too. It's a peaked upside down T wave. There's edema of feet. Management, acute renal failure, airway, breathing, circulation. They need fluid volume, particularly if you think that their problem is myoglobinuria from muscle damage, from laying in one place for a long time, or a burn or whatever. They need to have some fluid. So you need to protect the fluid volume. Consider all medications they're on, and we need to eliminate things that can, one of the things that can affect people with chronic use of non-steroidal anti-inflammatories can have acute renal failure from the metabolic damage on the kidney. Acute renal failure, unless it's treated well, even sometimes when it's treated appropriately, will go on to chronic renal failure because they get permanent loss of nephrons, depending on why they had the acute renal failure. End-stage renal failure is what we call people when they have to go to dialysis in order to adjust their pH and adjust their kidney is not able to manage their electrolytes. Sort of a demonstration of acute pitting edema, which can occur from chronic renal failure. It can also occur from chronic congestive failure. The usual causes of chronic renal failure are what causes acute renal failure or microangiopathic injury to glomeruli. Microangiopathic. What's the most common cause of microangiopathy? Diabetes. The little glomerulus itself is atherosclerotic and not functional anymore. Then tubular cell injury can occur, and interstitial injury. Those are generally from toxins, chemicals, and other toxins. But the most common cause in this country, and this is why, when Medicare came in, acute or chronic renal failure patients of any age basically get transitioned to Medicare. That makes them eligible for not only dialysis, but for renal transplant. So, systemic hypertension, diabetes mellitus, atherosclerosis, glomerulonephritis are the most common causes, but by far diabetes mellitus, which causes systemic hypertension, so the two are really together, and atherosclerosis. These three things are the most common cause of chronic renal failure. And the most common cause of all those things is diabetes. And we got a lot more diabetics than we used to have. Heavy metals, stones, obstruction of the bladder can cause tubular cell injury. Infections, including pyelonephritis, can cause interstitial injury. When you get impaired kidney function, your kidney maintains normal blood volume with proper balance of water, electrolytes, and pH. So if your kidney is impaired, you get increased sodium, increased water, increased potassium retention. So you get increased blood volume and increased salt load circulating. Your kidney helps you to maintain glucose, because it reabsorbs glucose from the kidney. And it excretes urea. So when your kidney has chronic kidney failure, particularly if the glomerulus is affected, you lose glucose, more glucose in your urine, and now that has a tendency to suck water out of your system and potassium. Remember Whitworth's basic rule. Potassium follows glucose. So you have overall a loss of potassium, general loss of potassium. Even though you're retaining it, you're losing it selectively now because you're losing more glucose in the urine. That has a tendency not only to deplete total body potassium, but it has a tendency to deplete your glucose. That then makes your system put more glucose into blood, which pulls more potassium out of heart muscle, any other muscle, the interstitial spaces, and puts it into the serum, which has a tendency then to load up your serum with potassium. So you get the effect of losing potassium, but also you have your serum as a higher potassium. And when we talk about hyperkalemia, we're talking about too much potassium in the serum. The renin-angiotensin loop is messed up because of the damage to the glomerulus. So your blood pressure control is lost. So it doesn't adjust to, it produces more angiotensin, which raises your blood pressure because it's not functioning, it can't sense it, it raises your blood pressure. So you get hypertension, and because you're not putting out enough of your erythropoietin, they become chronically anemic. Probably the best way to differentiate between chronic and acute problems is simply to ask the patient, have they had chronic, do they have, are they on dialysis? Simple question. That should give you an idea then to help you to assess whether they're having their acute weakness and maybe their palpitations is maybe due to the fact that they missed the dialysis, or their dialysis didn't go right sometimes, so they have hyperkalemia. So that gives you a hint as to what may be going on. Do they have GI complaints? GI complaints are often associated with acute changes in chronic kidney problem. Is there a change in the mental status? If they become more lethargic, it's probably due to increasing levels of urea, increasing levels of potassium. Obviously, abnormalities during physical exam are good. Uremic frost, some of the urea is sometimes excreted through the skin, through sweat, and ends up drying as little crystals on the lips, and it's called a uremic frost. It's not cold. It's just it's like they have a little bit of powder on their lips. I'm not going to go through that one. That's way too complicated. All right. Well, chronic renal failure. Monitor and support ABCs, establish IV access, regulate, fluid volume, and how do you regulate fluid volume? You're going to use their blood pressure as a method. We're going to put salt solution in them, even if they were going to have to go to dialysis. Vital signs, cardiac rhythm, get a 12 lead. Chronic renal failure will often present as headaches, edema, oliguria, weakness, fatigue, and hypertension. If they present as hypotension, you need to get some more fluid into them. ABCs again. Renal calculi. This is not a healthy kidney, obviously. Remember, you're concentrating your urine. You've got a lot of different things that are coming out, including calcium salts, struvite, which is related to proteins, uric acid, which is related to the breakdown of protein, cysteine, which is another breakdown of protein. All of these things, when they get too concentrated, they will precipitate out a solution. I don't know if you guys ever did that experiment where you would make a super salty solution of something and then put a crystal or put a piece of coal or something in it, and then it all precipitates and makes this nice little stone, makes this nice little pattern of crystals that conglomerate together and then make a thing. Well, that's exactly what happens in the kidney. Ordinarily, it doesn't make these monster ones. This is kind of a long-term ignored effect. This is known as the staghorn calculus. Ordinarily, it makes just a little stone that gets in the collecting system in the renal pelvis, and then it will break loose. And if it's of a certain size, it'll just travel down through the ureter without any trouble. If it's big, though, by big I mean if it fits tightly into the ureter, it will be pushed down the ureter by the force of the urine pressure above it. And the stones are irregular. They're not perfectly smooth, round pebbles. They're kind of irregular. And the lining of your ureter has more nerves per square inch than any other place in your body, for some odd reason. Makes no sense. but they say if life made sense, men would ride side saddle. So the stone goes down, and there are 3 places in the ureter where it can hang up easily, and that's at the renal pelvis, because it's a little narrower, where it goes over the brim of the pelvis itself, because it has a little bend there, so it narrows normally, and then it narrows a little bit as it goes into the bladder. So there are 3 places that it can really hang up. And so classically with the renal colic, the stone, you begin having pain in the flank, whichever flank the stone started in, and then the pain travels. It moves gradually down into the abdomen, and then follows the inguinal canal area, and then into the groin. And the pain is very severe. It's usually described as the worst pain a guy's ever had, and usually described as the worst pain a woman's ever had. And you can't find a comfortable position, and they get sweaty and nauseated, and it's really very aggravating. Incapacitating, usually. And you can follow the course of the stone by where the pain is, and it just works its way out. And generally speaking, most stones are treated by allowing them to pass, and most stones do pass. And if they don't pass, you have to go after them, one way or the other. Patient will be tachycardic. Yeah. They said, maybe it isn't kidney stones after all. I've never seen a patient with a kidney stone that I had to worry that much about their ABCs. You know, they think that, but no. Position of comfort, give them pain medication. Give them stuff for nausea. Don't worry if you think they're drug seeking. That's not your job to figure that out. It's our job to figure that out. Kidney stone is kidney stone is kidney stone. Now, start an IV, because if you increase the fluid, a fluid bolus will often help to push this. It'll increase their discomfort, but once you got pain medication, it's okay. And it will push out the stone most of the time. We use anti-inflammatories, IV anti-inflammatories to help to relax it. We'll often put people on steroids to help reduce the inflammation. And generally speaking, most kidney stones pass within a day or 2 or less. Testicular torsion only occurs in 50% of our population. Or the likelihood, it's basically a strangulation of the spermatic cord. The suspensory ligaments that hold the testis into the scrotum are a little bit lax, and the testicle has a tendency to be able to rotate. And if it twists on itself and twists off its blood supply, remember the blood supply started at the level of the kidney, you get terrible pain in the groin and testicle, but you also often get pain in mid-abdomen, sort of like somebody hit you in the stomach kind of thing. That's why, you know, if you get kneed, that's why you have this, you know, it takes your breath away. It's not because, it's because that nerve ends up at the level of your mid-abdomen, and that's where you feel it. So testicular torsion is an emergency, occurs most commonly in adolescent males. I've seen it up to age 40, but very uncommon. Usually it's adolescent males. And you get about anything from 2 to 3 hours on a total torsion of a testicle before the testicle is actually dead. So it's something we try to fix quickly. And the way to fix it is to take it to surgery, unwrap it, and then tack it down so it can't do it again. Yeah. So medical emergency. Now, urinary tract infections. Women get urinary tract infections far more often than men because the urethra is shorter, and it's nothing more than that. Sexual activity can increase the risk of urinary tract infection, but most urinary tract infection happen from standard normal bacteria that live in the vagina mostly. So we're talking about mostly gram-negative things like E. coli. Urinary tract infections in older guys is also E. coli. Most things that increase your risk of urinary tract infection are things like catheterized patients always get foreign body, more urinary tract infections. If you infect the urethra, it's called urethritis. If you have the bladder infection, it's called cystitis. Prostatitis is infection of the prostate. Pyelonephritis, infection of the kidney, the pilum of the kidney. Nosocomial infections are usually things you get in a hospital or a nursing home situation, and nosocomial is usually associated with instrumentation or catheterization. So old people in nursing homes, little old ladies are high risk for urinary tract infections, even if they're not catheterized, but anyone who's got a catheter is a walking time bomb for having urinary tract infection. And then they get urosepsis. So abdominal pain, usually pain in the bladder area, for if people are busy talking to you, frequent painful urination, that generally means cystitis or urethritis. Burning sensation is at least urethritis. Difficulty beginning and continuing to void. Your bladder doesn't like to empty itself if it hurts to do that. Strong and foul-smelling urine is not generally a sign. That's generally a sign of other things, but it can be the sign of urinary infection. But you all know. I mean, we've all been walked into a room in a nursing home, and you know that this person who's not acting normally has got to have urosepsis right now because it smells like urine. And they're not with it, and they don't have a fever, because a lot of times urosepsis in old people, they don't develop a fever. That's the cause of that's the cause of their problem. They always have similar past episodes. A younger person, alert and oriented, is probably restless, uncomfortable. They may have a fever, particularly with pyelonephritis. They may have pain over the kidney area with an infection of the. Incidentally, an infection of the kidney is an emergency. That needs to be hospitalized and treated with intravenous antibiotics and gotten control of. Obviously, vital signs vary, and most of the time with urinary tract infections, you don't have to worry about treating for pain. IV access, analgesic medication if needed. Okay, the end of this, and very quickly into ALPS. Just as a reminder, we're still in the ALPS. ALPS included, we're talking about an out-of-hospital cardiac arrest. The cardiac arrest you get called to, you have non-trauma involved, so it's a regular out-of-hospital acute cardiac arrest. Vascular access is established. Persistent recurring VFib or VTAC after one or more shock. So if you've given them a shock already, and the next time you look, they're in VFib, you're going to shock them again, but you could start the ALPS at that moment because you're given two shocks. So anytime you do the second shock, think ALPS. Can't use any open label amiodarone or lidocaine. There are protected populations we all know about, and a shock is any shock not counting the internal cardiac defibrillator. So if a public access machine is giving the patient a shock, if a non-ROC agency is giving the patient a shock, if you gave them a shock, that's a shock. That's the first shock. If the public access agency gave them 3 shocks, then you could start ALPS immediately, because those machines are not going to shock unless they're in VFib. We know that to be true. Persistent and recurring is exactly what it is. It happened again, and you need to shock the patient at least twice. That's recurrent, persistent. It happens anytime in your sequence of taking care of that patient. If you shocked them, they came out, and 10 minutes later they went back into VFib, that's their second shock, and that could be ALPS at that point. Drugs as soon as possible after you say, yeah, second shock. So as soon as possible after the second shock. If you've given the first dose, and the first dose, of course, is syringe 1A and 1B for normal-sized people. You give them that dose, they come back, and they again have VFib, VTAC on the next view, or they go back into it later on. Then you give the second dose, which is syringe 2. Got to use the ClearLink. ClearLink has been a little bit of a problem in the past. Be careful. Sometimes they're hard to make go on correctly, especially if you're if you're short-handed. So be careful. If you break a syringe, the patient, you still continue your treatment, but they're out of the ALPS at that point, so you can go to your standard treatment. Call that number, which is in your kits, for ALPS enrollment. Okay. All right, I got to briefly talk about this. Well, Mark, how are we going to get into this? Oh, there we go. Okay. To very quickly go through this one. Actually, Mark, I'm going to let you do this. Okay? What I'm going to do is I want to get out of this one. I want to get out of this. I'm going to do the case reviews and let you talk about the SUDS. Okay? Okay. I'm going to talk about case reviews very quickly. Hit play. Okay. Hey, this is our new confidentiality statement. Everything we talk about, even though I don't put the names up, obviously, anything we talk about, we'll have to kill you if you tell anyone. See, so no, this is all confidential. It's all under the state protection. You can talk among yourselves, but don't talk to outside parties about it. Okay, first one. 58-year-old male lying supine in bed, conscious, alert times 4. Has the history of renal failure, has been getting lab values down every week. Potassium was 7.1, and EMS notified transport. The patient has been bradycardic the past week, and they had stopped his amlodipine because they thought that might help it. But chief complaint, weakness, no other complaint. So, blood pressure was 92 over 60, pulse rate 38, and blood glucose 155. And the interpretation of the EKG is sinus bradycardia. Well, I wouldn't quite call that sinus bradycardia, but it's definitely bradycardia, and I guess you probably, okay, how many people want to find a P wave for me everywhere? No. So, this is hyperkalemia gone beyond the normal peak T wave kind of thing. I don't see peak T waves. The T waves that come down. The QRS is kind of wide. It's not wide to the point of being a ventricular QRS yet, but it's pretty wide. We know already the tip-off there. I always said that his potassium was up. In actual fact, the potassium was not 7. He was treated. They thought it was 7.1, but they treated him, and we'll go back to the treatment. They gave him calcium. They gave him albuterol. First thing off the bat, it's easy to do. Calcium chloride. Next thing. Calcium chloride, basically, think of that as a membrane stabilizer, particularly cardiac membrane. So it won't affect the potassium much, but it will stabilize that membrane for you. And what would be the next thing? Bicarb. Why didn't they give him sodium bicarb? Because you're out of it. Now, when you get a case like this, so here's my message on it. The drug problems right now are ridiculous, but I mean, how can you be out of salt water? You either have to get some, we're trying to get some maybe smaller bags, maybe some other formulation. I mean, my God, they're out of sodium chloride sometimes, normal saline. Turns out Vancouver Fire has sodium bicarb. So if you know you've got a person like this, ask the Vancouver Fire guy to, until they run out. And we're still trying to get some. But that's the trip. Okay. Now, here we have another one. Patient sitting upright. Anyway, he got there. He got treated with the albuterol and the calcium chloride, which, like I said, won't lower his potassium that much. You could have also tried some Lasix on it, which might have done some things, but his blood pressure was fairly low, so I wouldn't be too worried about that one. Even people who have chronic renal failure will get some result from Lasix. That's in your order for one of the last thing to do for that. His potassium was, because it had been checked that morning, at 7.1, and when he got to the hospital, it was 6.8. So it was definitely coming down. Now, albuterol lowers potassium by about 0.5 for everybody across the board, and that's exactly what it did for that one. Okay, here's a patient who is treated appropriately, but for the wrong reasons. Patient sitting upright, rocking back and forth, speaking full sentences, vomiting, chills past 3 days, hasn't been able to take oral medicines, states blood glucose reading high for 24 hours, last dialysis 2 days ago, and due again today. States previous episodes saying requiring admission to ICU for DKA and hyperkalemia. States he's been producing urine, but not very much. Boy, it's chronic renal disease. So, blood pressure is 220. Pulse 103. Pulse strength normal. Respirations. Gave him something for nausea. Blood glucose abnormally high. 12 lead. No elevation. No STEMI. Gave him some nitroglycerin. Pain scale. He's up. Gave him nitroglycerin. Remember, he's also hypertension. Didn't help too much. 228 now. Pulse at radio 106. GCS is 15. So here's his 12 lead. So his 12 lead. What do you see on his 12 lead? Well, yes, you do see some peak T waves here. You don't really see any peak T waves anyplace else. This is an abnormal thing down here. That's just a glitch. I also see criteria for hypertension. Look at the QRSs in these guys. I don't see any T wave activity over here. So. Now, interestingly enough, he was treated with nothing. And there was a discussion of the medics. And when I queried the transport medic, why didn't you treat him? I said, well, because I've been told by some of the doctors they didn't like to have the potassium messed with until they got a number in the hospital. Wrong. I'd like to know the name of anyone who's told you that. Because hyperkalemia needs to be treated. Number two, he said, well, I knew I didn't have any bicarbonate, so I didn't want to start any treatment. Well, albuterol was cheap. and easy. So that's also wrong. The thing is, he didn't need to be treated because this isn't hyperkalemia, because there's only the only peak T wave, which are quite impressive, are in these two leads. They're nowhere else, and they're in the two leads that have monstrous QRSs as well. Now, I don't expect you to be able to interpret everything. Now, that's not the point. It's just that the right thing was done for the wrong reasons. You know, one of my ex-partners used to say when we were talking about hiring physicians, he said, well, if you can't hire good ones, hire lucky ones. Okay, however that works out. This is hypertension. The T waves are peaked in that thing because they're big, just like the QRSs are big. Monstrous. So I wouldn't get too excited about it. But it would be nice if you could send that in, but I'm not sure the ER doc would have picked that out as different. The guy turned out to have a potassium of 4.4, 4.5. I mean, he has a normal potassium despite his past history. It's the way it works out sometimes. But when you see, just like when you see ST segment elevation everywhere, it's not an acute MI. It's a mimicker, usually pericarditis. Patient awakened, this patient awakened, mid-level person, awakened about 5:30 with 10 of 10 pain on the left side of the chest, non-radiating, sharp, and constant pain. No nausea, no vomiting, no shortness of breath, no diaphoresis. Has not felt well for 2 weeks, cough and weakness. Skin's warm and dry, chest expansion, tender to the left side of the chest with palpation. Always good to write down that pain is, now, not only is it tender to palpation, but does the pain reproduce the pain of the chief complaint? He says, yeah, that's my pain. No pedal edema, everything's fine. And he's brought in as a STEMI alert based on this QRS, this 12 lead. And I'd rather have you err in calling something a thing, but I believe that they call it, first of all, this baseline wanders a bit. So this one is suspect because this is not elevated. This is clearly looks elevated, and this one is too, but the baseline is kind of wandering here, so I wouldn't bet on that one. Is this elevated? Not very much. Some people argue that you shouldn't even call it unless it's 2 millimeters. I wouldn't worry about that. I want you just to call it if it's up. So this was called on this basis. The guy had basically normal vital signs and everything, and they didn't have to, it was during the middle of the day, so it's low impact. They don't have to bring the cath lab in from home. And this was his previous 12 lead was checked. It's exactly the same way. And he has costochondritis, just an inflammation of the costal junction from his cold flu that he's had for a week, 2 weeks. Okay to call it as a STEMI if you really think it's a STEMI, or call in and say, I'm coming in, we've got a guy with this doesn't sound like cardiac chest pain, really. Chest pain, constant, doesn't radiate, not associated with any other symptoms, and pain when you palpate the chest. Low impact kind of thing. Don't worry about overcalling. I want you to overcall them rather than undercall them, but we can try to heighten our thing. I'd be more anxious if I got called by the cardiologist at 3 in the morning, say that, hey, you know, I got awakened for this. But that's not my worry. 71-year-old male complains of dizziness. He states his history of ventricular tachycardia is usually self-resolved. Past history of MI, heart surgery, no chest pain, shortness of breath, no nausea, vomiting, sitting on the couch, alert and oriented, no distress, with runs of VTAC. And this is the fifth. I love this one because this is the 15. This is a LifePak 15, and it's recording. Clearly, it's not recording everything simultaneously because he goes through some normals and some kind of abnormals very quickly. And right in the middle of, leads 1, 2, and 3, he starts going into this VTAC and kicks along. And so how would we treat this person? He's alert oriented, his pulse rate is 90, and then he goes into the VTAC things, which is not 90. His blood pressure 152 over 127. How are you going to treat him? Amiodarone. Now, arguably, if you thought this was monomorphic VTAC, you could make him, and he was sitting there chatting with you like this, you could arguably say, well, I think it would be, if you saw the entire 12 lead looking like that, I would go ahead and treat him with, I'd try him on a little adenosine just to see. But not in this case, because clearly this is VTAC. He's going in and out of VTAC. And VTAC is treated with VTAC medicine, which for right now is amiodarone. And he did excellently with the amiodarone. He did excellently with the amiodarone, and his blood pressure is 138, pulse rate's 88 when he got down, and he went there, and he ended up. They ended up finding that he has a little bit more lesions on his. And they're going to work on his heart again.
Oh yeah, she's. No, you didn't. You didn't. Okay, real quick. For those of you who have been around long enough to remember when we did this the first time, the SUD study, they changed the name, I guess, Oregon SUDS. Essentially what this is we are drawing blood on sudden cardiac death patients in the field. And the purpose of it, why I need to stand here, sorry. The purpose of it is to determine genetic, they're trying to look at common genetic biomarkers in sudden cardiac death. It's being done in conjunction with Cedars-Sinai, Oregon Health Sciences University, Clark County EMS, Multnomah County, and I believe Washington and Clackamas County as well. Sudden cardiac arrest among Oregon and Washington residents by comparing clinical and laboratory findings in people without a history of sudden cardiac arrest. Okay. What's the purpose? What factors, what genetic biomarkers can we identify that predispose people to sudden cardiac death? They look at this in a comprehensive multidisciplinary evaluation. Basically what we do pre-hospital is we draw blood and they analyze it. We're drawing blood from, for us, it's going to be transport providers. So AMR, Camas, and North Country are going to be, it's just easier logistically to do it that way. Draw blood on sudden cardiac death patients. The SUDS group at the university are going to review all the clinical records that we produce pre-hospital. They're going to they're going to look at any autopsy results or if any of these patients get transported, they'll end up pulling medical records on the patients that are transported. They'll phenotype true sudden cardiac death patients. So what that means is sudden cardiac death for the most part, unexplained reasons. They don't have medical history. They're not chronic lung patients, congestive heart failure patients, cancer patients, etc. They'll look for phenotyping and determine, hopefully, anyways, if there's any sort of commonality between certain subsets of patients. Participating agencies, AMR, North Country Camas, logos didn't get on here yet. But basically, there we are going to track all sudden cardiac deaths in Multnomah, Clackamas, and Clark counties, and essentially draw blood on these particular patients. I'm not going to talk about that. Well, anyways, it's important to note that this study originally started, I believe, in early 2002 or 3, something like that. So it's been going on for a long period of time. They have determined some pretty significant things already. They've presented papers at the AHA, American College of Cardiology, and the Heart and Rhythm Society, and essentially what they found so far, and I can't get into too much detail about it yet, is that socioeconomic status is, they're determining, as a precursor, excuse me, to sudden cardiac death. Well, that's not really a genetic biomarker, and that may be common sense, but they're able to further define groups within socioeconomic status that are a little more prone to sudden cardiac death. They've presented this in Science. Genome stuff is really huge now. They're also using genetic biomarkers, and this is kind of a side note. They're using genetic biomarkers to determine the correct dose for pain medication, for antipsychotic medication. So genome study is kind of big, and we're going to be participating in that. So what do we do? Basically, we're going to collect blood samples on sudden cardiac death patients in the field. Who? Sudden cardiac arrest patients, even if they survive. Okay, so any cardiac arrest patients, we're gonna, and it's just a single. I think it's a red tube, which I think it says here in just a minute. We don't draw bloods on trauma patients, obviously. Any sort of violent death, i.e. hanging, drowning, overdose, we don't draw bloods on. Draw blood as soon as you start the IV. You can draw it IO as well, if you can. Actually, you can pull it up into a tube, IO. Obviously, don't interfere with resuscitation. Oh, it's a purple top, sorry. This is what the kit is going to look like. It will come, and sorry, John Griffiths was going to be here with the kit, but he got detailed to something else. Basically, what it's going to involve is the necessary stuff, the Luer lock, the vacuum tube to draw blood, and it's just one quick tube. You're going to draw it, put it in a biohazard bag, label it with date, time, your initials, patient name, the service you are with, and the run number. And if you have a face sheet, throw it in there. If not, so the important thing to note is everything that comes with it, place it in the bag, and it needs to go in the cooler. So everybody, your ambulance coolers, now that you don't have cooled fluids, you have room in there. And then I'm not going to get into deep patient care reporting because it's a regular chart, but just make sure you note that you drew blood and you entered the patient into the study, okay? And then include a copy of the code summary with your documentation, just like you normally do anyways. Consider it, you would document it as you would an ALPS case, or any other case for that matter. So the purpose of the study is to identify high-risk patients. So is there any genetic biomarkers that can determine high-risk patients, and hopefully they can do something about that. Improving resuscitation through faster response, i.e. certain socioeconomic groups, pre-identification of patients that are high risk. So this has pretty big impact on the stuff that it is that we do. We talked about that. This is the group that's doing it. You might recognize Dr. Jews in the middle. Ron Mariani's on the far right-hand side. And that's it. Any questions? We are going to start this here very soon, probably by the 1st of March. Thanks for coming.